After the emergence of HIV and AIDS, concerned scientists created International AIDS Society (IAS) to bring together experts from across the world and disciplines to promote a concerted HIV response. Hello there, you are watching The Last Mile with NACA, and I am Adesuwa Osuyi. Glad to have you join me. Today, IAS is a well-acknowledged platform that hosts the world's most prestigious HIV conferences, like the recently concluded International AIDS Conference in Canada. Stay with us for highlights of the event.
Established in 1988, the International AIDS Society (IAS) has grown to a global forum of over 15,000 members in more than 170 countries, making it the world's largest association of HIV professionals. It aims to galvanize the scientific response, build global solidarity, and enhance human dignity for all those living with and affected by HIV. In a bid to achieve its set objective, the IAS has, over the years, organized the International AIDS Conference, the recent being the 24th edition, held in Montreal, Canada, and virtually from 29th July to 2nd August 2022. The 5-day event calls on the world to come together to re-engage and follow the science. It will define future research agendas, shift latest evidence to action, and chart a new consensus on overcoming the HIV epidemic as a threat to public health and individual well-being.
After 4 decades of responding to HIV, we know that we won't reach our targets without involving all stakeholders at every level of the HIV response. This first fully hybrid event brings together delegates from all corners of the world to collectively re-engage at the intersection of science, policy, and advocacy to drive the HIV response. Science has shown us that once you get that virus down to undetectable levels, you will not transmit it on to your sexual partners. And science is edging us closer to a cure. But without financial investment, this will not happen. The recently released UN AIDS report says it loud and clear. We are not on track to achieve our goals. 1.5 million new infections were recorded last year, 1 million more than the target that we set for ourselves. We must do all we can to re-engage and get the HIV response back on track to meet our targets. Ladies and gentlemen, the program we've put together will outline the evidence that should be followed, highlight the gaps that science has yet to fully address, and call attention to the policies and practices that should be adopted to implement the science.
Today, we face an extraordinary opportunity. We now have the tools to end the AIDS crisis if world leaders act with courage and vision. I ask world leaders to picture a world where everyone has quality health care, a world that has rejected stigma and repealed all discriminatory and punitive laws, where everyone living with HIV has access to the best treatment science can offer. Today, we are a long way from that vision. Progress in preventing new HIV infections is faltering, but until everyone has access to the best that science can offer, we will never end this or any future pandemic. Together we can. We will end AIDS. I remain hopeful.
The opening panel discussion explored sources and evolution of the mounting apathy and why and how the world must re-engage and follow the science towards our shared goal to overcome the HIV epidemic as a threat to public health and individual well-being.
In the last 4 decades, we've made incredible scientific and public health strides. We know more about this virus than any other pathogen. We have treatment that is now simplified to a single pill a day. We have innovation in our prevention measures that is nothing short of revolutionary, and even more innovation in the pipeline. But stunningly, we still have 1.5 million new infections. We have 38 million individuals to find, start, and help stay on life-saving therapy. 1.7 million of them children, almost half of whom we haven't actually found. We still have stigma to overcome and ideologies and laws that prohibit people from seeking the care they need. Many of the folk who live with HIV now face new challenges, such as comorbidities, cardiovascular, mental health, cancer, that require us collectively to think about how we can position HIV within a broader global health strategy toward better health and well-being, even for the least well-served among us. We have missed the targets we set ourselves pre the COVID-19 pandemic and the war in Europe, and the last 2 years have blown us further off our course. The epidemic is far from over for those individuals. It's far from over for us. We now need to tell a truth that convinces the world to get back on the bus.
The first thing is that we need to define we. When we talk about, who are we in terms of following the science, and are we heard, and are we doing the work that needs to be done? Communities and civil society since the beginning of time in the epidemic have started with initiatives and research. GMP Plus and APN Plus and many of the regional networks have started working on the stigma index, collecting information, showing the world that these things need to be addressed. We have heard for the last decade or so the need for societal enablers for the communities, removing violence, removing stigma and discrimination, investing in communities. We've been reiterating these messages for the last 10 years. Governments have come and gone. We are still here. We are still not being heard. There needs to be action now. And I think the main thing about this is that when we talk about ending AIDS by 2030, what are we really doing to address stopping HIV transmission? U equals U needs to be implemented everywhere, immediately, now. We need not only the politicians and the lawmakers to understand prevention. We need also healthcare workers and the health workforce to be able to provide quality healthcare to us without any discrimination and stigma.
The struggle is at a crossroad, and it requires that we follow the science. And in my view, the science will lead us to two things. Will enable us to know the gaps and will enable us to close the gaps. And only science can help us to address that. I'd like to emphasize two things. One is a message of hope, and secondly is that we cannot surrender. So the message of hope, thanks to the contribution of PEPFAR in this fight, which is driven by strong political commitment. This year, we have seen that more than 12 countries from high-burden countries affected with HIV/AIDS are reaching the 90-90-90 goals. More than 20 million people received life-saving treatment between last year and this year. This is up by 17 million compared to last year. We will be announcing that 5.5 million children were born HIV-free thanks to comprehensive programming. And that because of COVID, and because of our innovation, collective innovation, more than 480%, there was a 480% increase in multi-month dispensation of drugs. And that about 4.3 million self-testing was conducted, and 2 million new clients received PrEP. That is encouraging. If we stay resilient and continue to focus on what we have to do, with political commitment, political will, and political leadership, we cannot surrender. We can continue to fight and hopefully achieve the goals we've set and commit ourselves by the year 2030.
Much work has been done in the fight against HIV/AIDS in Nigeria. However, more work needs to be done. Together, we can end AIDS by the year 2030, even amidst coronavirus pandemic.
Educate yourself. This is crucial in the fight against HIV and AIDS.
Get tested. The only way to know for certain your status and stop the spread.
Get involved. People with HIV and AIDS need care and support.
Say no to stigma. Stigma prevents people from getting tested and those living with HIV from treatment.
Spread the word. The more we educate others about the disease, the better we can fight it.
Adhere to COVID-19 prevention protocols, wear a face mask, and maintain physical distance in public places.
Remember, only united can we defeat HIV to finish and end AIDS by the year 2030. Get tested today. Let's fight HIV to finish in Nigeria.
Nigeria was well represented in several sessions and workshops.
In Nigeria, there's an adult prevalence of 1.4%, and that translates to about 2.1 million people living with HIV. At the moment, we have up to 1.7 million on treatment. In 2018, which was about the period that the conversations around AHD started to gain momentum, there were about 32% of PLHIV who were initiated on ART with CD4 count below 200. In 2017, most of us here know that WHO released guidelines, and based on that, we developed our own homegrown guideline incorporating AHD package into the 2020 guidelines. And so what we've done is to have a phased approach to implementation. So the first phase of implementation in Nigeria happened in 4 states: Akwa Ibom, Anambra, Lagos, and Rivers states. Those 4 states were selected based on the fact that they're high-burden states. And the Ministry of Health, working with CHAI, quantified and procured AHD commodities with UNITAID support. So within the 4 states, we've implemented in 28 facilities. For Nigeria, that's relatively small, but it helped us to learn a lot. Learning from what we did in phase 1 implementation, we started a national rollout. Nigeria has 36 states and the Federal Capital Territory. So for purpose of programming, I'll refer to it as 37 states. So right now we have 30 out of those 37 states. There's been capacity building to initiate AHD package of care among health workers. What are future priorities? The first is pediatrics. And of course, if we know, we all know what the guidelines for WHO are as it relates to children. And so the cohort of children who are HIV positive, out of that, there would be a very large proportion that belong in this category. So for us in Nigeria, especially where case finding, treatment, and access for children remain relatively low, below what we have for adults, this is really a priority for us. The second is to ensure that we can expand the package of care to include other opportunistic infections. And I think this is, again, one area where we need to think context. And so what opportunistic infections should we look at from a country-to-country perspective, identifying what is relevant in each situation and ensuring that we can include it in the package and prioritize it.
My question is that having access to the sexual and reproductive health and rights can decrease child marriages, decrease teenage pregnancies, and prevent transmission of sexual infections. My question is that what should we do so that we are able to respond holistically to young people's needs on SRHR and HIV?
All right, thank you very much. So to respond to this, I think we need to start looking at reviewing, reforming, and also establishing policies that promote access to comprehensive sexual education and services without any form of discrimination for adolescent girls and young women, especially young women living with HIV. We also need to enhance responsiveness to family life education programs for in-school adolescent girls and young women, because while our programs sometimes look at the general populations and out of school, there's also need for us to start contextualizing it to the in-school. And I know FLHE is a usual name across the globe, but we need to also do that because I think I consulted along Y Plus for UNESCO for a document that looks into HIV for young people and SRHR within the context of in school. So we need to also see how we make that responsive for them. Then also, I think we need to eliminate all forms of stigma and discrimination, and also cultural and social norms surrounding access to SRHR. So also we need to deploy a human-centered design approach and put AGYW at the center of our programs. So we need to stop doing the thinking. And I appreciate Dr. Paula here from UNAIDS, who said she will say less. She wants to hear what the young people will say. So human-centered approach requires us to listen. Sometimes you think I need prevention, but probably maybe I need economic empowerment. Sometimes you think I need treatment, but probably maybe that moment I need prevention. So we need to deploy human-centered approach to it. And lastly, we need to fully finance it and see how to economically empower these adolescent girls and young women. Procuring sanitary, as little as sanitary pad is, many adolescent girls cannot be able to buy it. And we know the importance of this. So we need to ensure they are fully economic empowered and self-sufficient to be able to see how access to service and also meeting their sexual reproductive needs and also access to HIV related services, it's in a way that they are able to afford it.
Long-acting HIV treatment products clearly hold a lot of promise, we know, to improve the end-user experience and to improve health outcomes. However, it's clear that introducing these new products will come with their own unique challenges. So from your perspective, what will be the biggest challenges that ministries of health like yours will need to address when it comes to introducing long-acting HIV products?
Thank you. I like to think about the challenges from two perspectives. First, from the health systems readiness perspective, and also from the patient perspective. So speaking about health systems readiness, there are a number of things that we have to consider and which pose potential challenges. You have to think about the tools for monitoring. Think about how you reflect and review what you work with currently to ensure that you can capture all the different regimens that are in place. Service providers. Sometimes care providers are the most skeptical about some of these things. So you have to also think about how you deal with that. In addition, there's all the complexity around the capacity. For us in Nigeria, for example, which is a very large country, the number of facilities, the number of points of care, that is huge, a huge endeavor when you think about how you build capacity around whatever new regimen is coming on. Of course, there are a lot of questions that arise when you think from a patient perspective. So there are questions that ministries of health may not be able to answer at the moment. So what are the implications for me? How does this affect me in terms of the efficacy? Is this going to work for me? If there are issues around resistance, how do I switch? What does this mean? So a lot of that is going to come into play as we think about rolling out. Also, there will also be issues around cost. So not just in terms of the cost of the commodities compared to existing commodities that are being used, but cost in terms of the tests that you're required to do before a patient is placed on this regimen. There are a number of things. So resistance testing, for example, in Nigeria, that is not, it's a cost to the patient at the moment. And that is going to be critical as you talk about long-acting ARVs.
We have about 1.7 million people that are living with HIV. And in terms of the 95 cascade, 90% of people know their HIV status, 86% are on ART, and 72% are virally suppressed. So STAR is a catalytic project funded by UNITAID through PSI, And the goal is to create that enabling environment for the introduction of HIV self-testing in the country, to demonstrate and pilot different service delivery model for HIV self-testing and be able to scale up through other funding mechanisms such as PEPFAR and Global Fund. So we work in the area of policy and planning. We'll be able to integrate HIV self-testing into the national ATS guideline. In terms of product registration, before this project started, we have just one HIV self-test, which is Oral Sure. But we're able to support the Laboratory Council to introduce additional 3 products. We now have Abbott, we have Mylan, we have Easty. In terms of distribution, 43% of our distribution came from facility model, and 38% came from community, while the rest accounted for the remaining percentage. Also, look at the various models. The highest yield is from the KP model. Last year, key population continued to drive HIV epidemic, and HIV self-testing also offers opportunity for us to be able to reach these people and empower them to be able to test themselves. 4.9%, and the lowest is from the private sector pharmacy model. In conclusion, I would like to say that HIV self-testing is acceptable and feasible across diverse settings, population, and age groups in Nigeria. We have been able to demonstrate this. The hard population, the men who don't come to that facility setting, through the community-based model and the activities of the community-based organization, we have seen that great impact on that and ability, being able to reach these people, offer them this kit and being able to use it and link them to care. Achieving a high return rate of results is possible across all models. We have said that about 97% of the results were returned across all the 4 models, and we can attribute this to the positive messaging, telling people the value addition that HIV self-test is bringing to them, helping them to live a positive lifestyle, helping their partner to stay healthy. These are the messages that we are reinforcing while distributing this test kit. Rather than say, oh, if you are positive, we are going to link you to care, we are going to give you this and that. The emphasis should be on the positive messaging for this population. We need more experience to understand the potential impact of each model to inform scale up at country level, and we are very excited that PEPFAR is already scaling up this. Global Fund is already procuring additional kits, and that's the goal of the United Catalyst Funding.
With all the critical issues addressed and key recommendations put forward during the 2022 International AIDS Conference, participants are expected to apply the knowledge gained towards ending AIDS as a public health threat by 2030.
Sister! Where you dey rush dey go like this now? Take am easy now.
Na hospital I dey go to do HIV test.
Na everything you dey do HIV test. Before you carry belle, you do HIV test. Now you dey rush go do another HIV test. Wetin you dey find, you go see am o.
No be so, my sister. HIV test no be bad thing o. Na make I know my status so that no matter the result, my pikin no go get HIV.
HIV fit pass from mama to pikin?
Yes o. During pregnancy or labor or even when we dey breastfeed the pikin. Yes, and my husband dey road dey come sef, he go meet me for hospital. We go do the test together.
Hey, your husband na man he be. But wait o, una no dey fear. What if the result come out positive?
Fear wetin na? HIV no be death sen ten ce. And medicine don dey to take manage am. See, nowadays people wey get HIV, dey live their life normal like everybody else.
You sure say I no go follow you go do my own so?
Wetin you dey wait for now? Come make we go jare. With quick action, we fit stop this HIV waka from mama to pikin. Go do your own HIV test today.
For more information on HIV and AIDS and related diseases, or to report suspected cases of stigma and discrimination, violence and human rights violation, please call the National Call Center, toll-free on 6222. Reach us via social media at National Call Center or email callcenter@naca.gov.ng and visit our website on naca.gov.ng. Thanks for watching. And as always, continue to support the HIV response. Do not stigmatize or discriminate people living with HIV. Avoid indiscriminate sex. And lastly, know your status and take action. Till next week on The Last Mile with NACA, I am Adesuwa Osi. Goodbye.